A very good morning to all of you. Welcome to another episode of Sri Knowledge Academy weekly Sunday webinar series. And today we have another very interesting topic for you to join in. And it is a topic which has been of a debate in the recent past as well. So before moving on to today's lecture, let's go to see some housekeeping rules. The webinar link will be open for you to join in from 9 to 9:50 a.m. No late attendees will be permitted to join thereafter. You have to stay until the end of the lecture to get the e-certificate and the CPD points. And the CPD points are strictly adhered to the NCCPD guidelines. Kindly keep your mics and the videos turned off during the lecture. If you have any questions, you can ask at the end of the lecture or you can type it in the chat box. Okay, let's move on to today's topic. Today's topic is chronic kidney disease of unknown origin in Sri Lanka. And to discuss upon that topic, we have Dr. S. Sasikanth, Acting Consultant Nephrologist, District General Hospital, Vavuniya. Dear sir, thank you very much for joining with us today. And I invite you to deliver your timely lecture. Thank you.
So thank you very much for your kind introduction, Dr. Malik. So today discuss just brief introduction to the CKDu in Sri Lanka. So I'm going to just discuss the basic information that would be helpful in day-to-day clinical practice. So I'm not touching anything regarding the research or extreme of CKDu. So as you all know, CKDu still is a gray area because we don't know the cause and where we are in future, what is going to do. So I think doctors who are working in North Central and Northern province, most of they are aware of what is CKDu. So without wasting my time, so we'll move into the topic. So outline, so we are going to discuss today definition of CKDu. So CKDu prevalence in Sri Lanka, risk factors for CKDu, and what are the biomarkers available to diagnose CKDu, and treatment and prevention. So what is CKDu? There is a misconception. Usually doctors, so if the patients like creatinine around 2, and we are investigating for the cause for history, extreme history level and investigation. We don't know the cause for the CKDu. So during that time, so we are mentioned at CKDu and question mark. So question mark mean we does not know the cause, but that is not mean that is CKDu, because CKDu there is a definitive diagnostic criteria and exclusion criteria. So how to diagnose CKDu? So CKDu is not a exclusion of other diseases. So what is CKDu? So still the mysterious kidney disease in Sri Lanka, because we don't know what is the triggering factor or culprit for CKDu. So these are the two definitions of CKDu. One is a clinical definitions, other one is a pathology. It's based on the biopsy. So clinical definition is based on presence of CKD in absence of any secondary causes. The most commonly used clinical definition is the one developed by the Ministry of Health Sri Lanka. This definition requires the following. So age is more than 80 years. So estimated EGFR less than 60 and absence of major disease like diabetes mellitus, hypertension, and glomerular disease or neurological disease. So second one is a pathological definitions. That means the definition is based on presence of histological finding of chronic tubular interstitial nephritis in absence of secondary causes. So CKDu patients usually do the biopsy. Most of the findings are related to chronic interstitial nephritis. So usually caused by infections and autoimmune disease and other drugs. So absence of these three, and there are inclusion criteria. In biopsy shows chronic tubular interstitial nephritis, so we can take it as CKDu. So, however, this definition is not always possible because we are not doing the kidney biopsy for almost all patients. So what is the exclusion criteria for identify the suspected CKDu? So these are the factors are there, so we can easily exclude that is not CKDu. So one is urine protein creatinine ratio is more than 300 milligram per gram. This means the nephrotic range proteinuria is more than 3 grams, because CKDu usually causing mild proteinuria or absent proteinuria. So diabetic based on self-report of diagnosis or the based on treatment or capillary random blood sugar more than 200. So basically, the patient having a diabetic, so that is exclusions. So hypertension based on treatment with more than 2 drugs or untreated blood pressure of more than 160 over 100. That means the CKDu patients usually having a normotensive or mild hypertension. The patient having a high blood pressure, that's which control need 2 drugs, or the blood pressure is more than 160 without treatment. So unlike CKDu, so something else. So acute kidney injury that require the hemodialysis in the past based on history or documented evidence. So patient having a CKD now stage 3 or 4, there are past history of AKI, but that required dialysis. So unlike CKDu, because CKDu AKI is very mild disease that won't require the dialysis. So otherwise the age is more than 70. So these are the major points. If they are, so that we can safely exclude that is not CKD. So when it's moved the prevalence in Sri Lanka, since the 1990, a new CKD where no obvious cause is identifiable has been described in Sri Lanka. This new condition has resulted in rise in incidence of CKD in rural areas and has been aptly named CKD kidney disease of unknown origin or CKDu. So alternately, suggested names for these conditions include chronic agriculture nephropathy or CAN or CKD of multifactorial origin. The prevalence of CKD kidney disease of unknown etiology in Sri Lanka is significant, with estimate ranging from 15 to 20 of adult populations in some areas. So you can see 15 to 20 mean that is a major percentage of population affected by CKDu. The prevalence of CKD in Sri Lanka is highest in North Central Province and other part of the dry zones. However, CKDu has also been reported in other part of the country, including the wet zone. So most patients are encountered in North Central and North Province. So further, so according to the 2019 studies, the prevalence of CKDu among adults in North Central Province of Sri Lanka around 18.3. In 2021 studies found that the prevalence of CKDu among adults in Anuradhapura district is 15.4. In 2022 study found that the prevalence of CKDu among adults in Anuradhapura district of Sri Lanka around 17.2. So these are indicate the more prevalence in CKD in Sri Lanka is North Central and North. So majority of high percentage of adult populations are affected by CKDu. So approximately the 90% of impacted families engage in paddy farming or vegetable farming or both. So most affected people live in rural and remote communities and limited access to the modern healthcare. So many cases are young to middle-aged male farmers who are involving in the rice farming or other agriculture. So communities that save drinking water from shallow wells or tube wells. Basically, the CKDu populations are mostly uh, uh, people are affected who are working in the paddy farm or the agriculture environment. At the same time, they are taking the groundwater from tube wells and shallow wells. So usually patients are middle-aged farmers around ages 40 and 65. So predominantly male than female and familiar clustering. There are family history of CKDu as well. So so CKDu hotspot in Sri Lanka, you can see the right-hand side, mainly the North Central Province, including the Anuradhapura, Polonnaruwa, so major prevalence area in CKDu. So last decade, we found a lot of cases mainly in Anuradhapura and Polonnaruwa, as well as the other district like other Badulla and Ampara, other area also we affected by CKDu. But luckily in Jaffna and central western province into the district, so usually is not endemic for CKDu. So mainly CKDu populations are including the Anuradhapura and Polonnaruwa. So not only in Sri Lanka and also in worldwide there are several endemic areas. Example like you can see in the red mark areas, Mexico and Central America, and India is a southern India, state of Andhra Pradesh, and Odisha in Sri Lanka is predominantly in the North Central province. So CKD not in Sri Lanka is all over the world most prevalent. So when moving to the risk factors are thought to be contributing the high prevalence of CKDu. So what's the reason for patient develop CKDu? What are the trigger factor and what are the risk factor for the CKDu? So mainly, so agriculture practice. So usually the patient, uh, pesticides and fertilizer has led to the contamination of soil and water. So major risk factor. So research found for the patients are affected in CKDu, they did urine and blood sample for these are the pesticides and fertilizer. So they are need to be can be detected in their urine CKDu. So we are assume maybe these agriculture chemicals are culprit for CKD, but not confirmed, we assume. So second one is the drinking water quality. So many people in Sri Lanka usually they consume the groundwater from drinking tube wells as well as the shallow wells. So these are the major metals. So usually heavy metals like cadmium, lead, arsenic, and fluoride are mixed in this water, and we can causing of CKDu. So other one is a diet and lifestyle. So Sri Lanka diet typically high in carbohydrate and low in fruits and vegetables. These are the risk factors. So mainly agriculture practice, these are the chemicals and water containing heavy metals like cadmium, lead, arsenic, and fluoride, as well as the hot climate. So usually farmers are affected, usually they have a background history of hot climate exposure. And excessive use of NSAID, that's also one of the risk factor for CKD. So these are the other factors now, like lower socioeconomic class or poverty. And there are some infections, leptospira and Handa, I will discuss in later. Other one is a family history of CKD. Yes, there are CKD running for the family. And genetic factors and consumption of sugar containing dehydration drinks. So these are the minor involvement of CKDu. So these are, we are assume these are the, probably these are cause for the CKDu, but still not proven. So this is research on the relationship between the water quality and CKDu in Sri Lanka. So some key finding of this research include one, the 2021 studies published in Journal Environmental Research found that the people with CKDu had higher level of cadmium and arsenic in their blood and urine than the people without CKDu. So that's why we assume that probably this is due to this cadmium and arsenic and fluoride. Other one is the exposure to fluoride in drinking water may be also associated with increased risk of CKDu. So 2020 studies published in Journal Environment Health found that living in areas with a high level of fluoride in drinking the water, they had high risk of developing CKDu. So in 2022, studies published in Journal Science of Total Environmental found that significant proportion of drinking water source in Sri Lanka exceeding the World Health Organization's guidelines for cadmium and arsenic. There are high concentration of cadmium and arsenic in CKDu endemic area. So we did, earlier I mentioned leptospira and Handa infections are potentially risk factor for CKDu. So who are the patients are affected by the CKDu? They are seropositive for and anti-seropositive for leptospira. So most of the patients are IgG positive for leptospira and Handa virus. So we'll assume there may be some link between the CKDu and leptospira. Maybe leptospira is one of the trigger factor or the leading risk factor for CKDu. So what research find? So other one is a genetic tendency. You can see some patients are in, we are diagnosed CKDu, there are family history of CKDs, mainly the female clustering, familial clustering, male more than female. So majorities are singleist. So there are some genes are encountered or genetic tendencies, some variant of SL313A3. So actually it's encoded sodium dicarboxylate transporter. So because of variant can develop in CKDu. So it's in there are family history for CKDu. Then we talk about the clinical features of CKDu. So what are the features of CKDu? So usually early stages of CKDu, you may not cause any symptoms. So CKDu until end stage, patient doesn't have any symptoms. So just they are living a normal life. So asymptomatic until end-stage CKD. So eGFR less than 15, patient doesn't have any symptoms. Patients usually normotensive and only mild hypotensive and no evidence of edema. So usually it's a normotensive, so mild hypertension. The edema, hypertension are usually a later stage. So earlier stage, asymptomatic. And proteinuria mild or absent. So actually it's no hematuria, mainly it's no active sediment in the urine. So usually low potassium and elevated uric acid. And ultrasound examination of kidneys often show somewhat small kidney with decreased cortical thickness. Usually creatinine 1.2 or sorry 1.82. The most patients are scan evidence of small kidneys. That's the features of chronic tubular interstitial nephritis. And there are elevated tumor markers. So when these patients are from north central province like Vavuniya or Capeticola, a patient coming with creatinine 2, usually asymptomatic. So in history wise, patient having agriculture environment or exposure to this groundwater, and there the blood pressure is usually normal or mild elevations, UFR perfectly normal, no proteinuria, no hematuria, and so we assume it's probably due to 99.9% CKDu. So it is a scan, most of the kidneys are small kidneys. So mostly background history of this high prevalence area, with these are the features, we can say this is probably due to CKDu. So no need for the biopsy, just keep an eye and just monitor the patient. So this is an important thing. CKDu is not a CKD, it's not a chronic. So it can occur in acute presentations. So you can see some patients, you can the patients after the hot environment, they're working farmers after the exposure to hot environment or after the harvesting. So usually they are complaining of fever, most of them low-grade fever, nausea, back pain, vomiting, headache, or it's usually non-specific symptoms. So you can check the blood pressure is normotensive. So mildly elevated creatinine. So you can say UFR some leukocytodiuria and neutrophils slightly high. So this is, we have to think, it may be it could be acute presentation of CKDu. So most of the time, patients from farming, so after the harvesting, they are complaining of these non-specific symptoms. So we are thinking, so it may be a mechanical pain. So we are giving NSAIDs and SAID. So remember, so NSAID usually is culprit, trigger for the CKDu. So just do the creatinine and see, so mild creatinine elevation, we can think maybe due to CKDu. So we have to monitor the patient in 1 week or 2 week time. So see the response of creatinine. So if it is persistently high, so we can refer back to nephrologist, or it is came down to normal creatinine. So we assume it's maybe a CKDu. So we have to advise preventive measures for that. So it's a very important point in CKDu in acute presentations. So histology, usually we are not doing the biopsy unless there are some atypical features. Patient presented with the background history of agriculture exposure, creatinine 2, but kidneys are normal size kidney. There are some proteinuria. So we are thinking it could be a CKDu or it could be a something else. So any glomerular pathology. So in that case, only we are doing the biopsies. So typical features in background of agriculture or the endemic area, usually we are not doing the biopsy. So if you do the biopsy, they are finding most towards tubular interstitial lesions. So usually tubular interstitial lesions are primary, and tubular atrophy and interstitial fibrosis are, and periglomerular fibrosis. Usually immunofluorescence are negative, and usually glomerular lesions are very rare. So mainly tubular interstitial inflammation and fibrosis are the major finding for CKDu. So what are the biomarkers in CKDu? So these are the biomarkers, measurable substance that can be used to indicate the presence of severity of the disease. So biomarkers in CKDu can be used. So one is screened for CKDu in high-risk population. So diagnosis of CKDu, so monitor the progression of CKDu and assess the response to treatment. But these are the biomarkers, are not specific for CKDu, because any disease, any etiology causing tubular interstitial damage, it can elevate it. So it is not specific for CKDu, but the background history of we are suspecting CKDu, these are factors are elevated, so we can think it maybe could be a CKDu. That's all. It's an important note. There's no single biomarkers perfect. and the combination of biomarkers may be necessary to accurately diagnose and monitor CKDu. So more research is needed to validate these biomarkers and to determine the severity and sensitivity. So these are the biomarkers more usually in the tubules and interstitium. So when we get damaged tubules, these are the biomarkers get in the serum, so we can elevate in serum level. So actually we are not in our setup, we are now in even the private sector, I don't think it is available for biomarkers. So treatment, so unfortunately, there is no specific treatment for CKDu. The treatment is supportive and directly at preventing the progressions and treating the signs of symptoms of chronic CKD. The treatment if the patient having hypertension or mild proteinuria, so we can start ACE inhibitors or ARB. So no definite treatment of CKDu. So if the patient develop complications, so manage the complications. So blood pressure high, manage with antihypertensive like ACE inhibitors or ARB. Still, we don't have a evidence of trying steroid or any immunosuppressive in treatment of CKD, just for supportive. Yeah. So it's a very important. So CKDu is prevention because we don't have a treatment or we can't cure the CKDu. So prevention is important. So usually the avoiding exposure to environmental toxins, usually the agriculture and toxins and fertilizer and pesticides. So using the water filter to remove the toxin from your drinking water. So we are nowadays the established RO plant system, so we can remove the toxins and hard element of the drinking water. So wearing the protective clothes and equipment when working in environment where toxins may be present. So protecting yourself from the occupational hazard. So wearing appropriate personal protective equipment such as masks and gloves. Wash your hands throughout the after work, especially in agriculture. So avoiding bringing the work clothes home with you. So excessive exposure to heat in connection with hard physical work performed over the many hours. So hot environment is one of the risk factors for CKDu. So better to avoid. And advise to drink adequate fluid that contains sufficient sodium and potassium. Usually it's normal water, so we can drink adequate amount of fluid. That's the prevention of CKDu. So avoid NSAIDs at least during the season of high risk duration. So usually after hot environment, I already discussed the farmers after this page complaining of non-specific symptoms. Please do the creatinine Cs, maybe a CKDu. So don't straight away prescribing or NSAIDs or other. Even you can give the Panadine, other things. So better to avoid NSAID because that is trigger the progression of CKD. Maybe later stage patient they end up in the established CKDu. So third, maintaining the healthy diet and lifestyle. So eating a balanced diet that include the plenty of fruits, vegetables, and grain. Limiting your intake of processed food, sugary drinks, and saturated and unhealthy fat. So do exercise regularly and maintain the health weight. So important thing is getting regular checkup and screening. So prevention is. So these are the key points. So that the government of Sri Lanka has taken a number of steps to prevent CKDu. So you can see the drinking water aspect. So government has invested in water purification plants, the RO plant, and water distribution system to provide safe drinking water to all communities. Usually the CKDu plant, you can see the villages having the water distribution systems are there. Other ones are reducing exposure to the environmental toxins. The government has banned use of certain pesticides and fertilizer that has been linked to the CKDu. It has launched a program to identify the cleanup contaminated groundwater wells. And other thing is health education awareness. So this is an important one. The government has launched its education campaign to promote the healthy diet, exercise, and other healthy measures to prevent the of CKDu. So investing the research and important thing is early detection and screening. So for patients, usually we are screening in endemic areas. So you screen at least use UFR and creatinine. So screening is important. So finally, the progression of CKDu. So usually CKDu slowly progressive disease in majority is usually patient having a years and years marginally creatinine is rising. So it is not a rapidly progressive disease, like a slowly progressive disease. So mineral-borne disease and other CVS or cardiovascular risk are less compared with other CKD. And young people who present with earlier stage of CKD, that is progress fast. slow progression in females, and hypertension is a risk factor for fast progression. So always treat the hypertension. So enalapril significantly reduce the hypertension as well as the proteinuria. So in future of CKD in Sri Lanka, so in future Sri Lanka, the future of CKD in Sri Lanka is uncertain because this is still not fully understand and there's no cure. So we don't know the cause. We are assuming these are the factors triggering the CKDU, but we are 100% not sure these are the factors for CKDU. So, however, the government of Sri Lanka is taking steps to address the cause of CKDU, including improving the access to safe water drinking and reducing exposure to environmental toxins and promoting health lifestyle. If these initiatives are successful, it is possible that the prevalence of CKDU in Sri Lanka could be declining in future. However, it is also possible that the disease could continue to spread, particularly if new risk factors are identified, because we are assuming this is due to agriculture, this is water, this is due to hot climate. So we are established to prevent these measures, but we don't know. Maybe later on futures, maybe develop a new factor that is established CKDU. So future of CKDU in Sri Lanka still is question. So take home message. CKD is a serious kidney disease in that affecting the million of people in worldwide. Asymptomatic until end stage. The exact cause for CKD is unknown, but exposure to pesticide, heavy metals, genetic are the major risk factors. Prevention better than treatment. Stay hydrated by drinking plenty of fluid throughout the day. Avoid strenuous exercise or activity in hot weather. Eat a healthy diet that is low in salt and high in fruits and vegetables. So always remember patients who are from CKDU endemic areas, their background history of agriculture or taking groundwater, so marginal creatine, rice, UFR, no proteinuria, so marginal hypertension. So always think about CKDU. So probably it's a 99.9% CKDU. So that's all. Thank you.
Thank you very much, sir, for your very informative lecture. I think we all got a very clear idea about the CKDU, and we have some questions. One is already in the chat box. Is high protein diet is a risk factor for CKDU? I'll repeat the question, sir. Is high protein diet a risk factor for CKDU?
So yeah. So once a patient develop creatinine high CKD, we are recommend to reduce the proteinuria. But there are high protein diet. There's no evidence of taking high protein diet that more prone to get CKD. But patient develop CKDU, usually we are restricted to protein because it's difficult to handling the high amount of amino acid in this in background of CKD. So high protein diet, I don't think that is a risk factor for CKD.
Okay. So there are some other questions which has been asked by attendees before the lecture. I have picked some. One question is why hypokalemia occurs early in this CKDU phenomena?
Sorry, hyper.
Hypo, sir.
So the CKDU usually this pathophysiology you can see the tubular interstitial disease. So tubular interstitial disease is the one is the features suggest your hypokalemia because of the tubular exchange. So unlike other CKDU, it's like chronic glomerular disease, diabetic patient CKD, mostly they develop hyper, but tubular interstitial disease mostly hypo, but it can occur any site.
Okay, sir. Then we have another questions. We have a CKD clinic done by MOs at our hospital. I would like to know when to refer patients to a tertiary care at what stage.
So usually whatever it is, we are recommended EGFR less than 30. So we refer to the nephrologist. So that's the ideal setup. But patient is stable, like CKD is a slowly progressing disease. So we can wait. It's like a EGFR less than 20. That is depend on the cause. The diabetic patients, glomerular disease rapidly progress. So we have to refer then and they are EGFR less than 30. But CKDO mild disease, we can extend something like EGFR 25 or 20. So we can wait. So that is depend on clinical. But ideal way refer back when the EGFR less than 30. So not go by the creatinine, just EGFR.
Okay, sir. There's one more question. Can this condition recur in a transplanted kidney of a patient So diagnosed at CKDu at early stage, CKDu end stage, sir.
So I got sure. Sorry, I'm not sure clear about it. Okay.
Yeah, in a patient who underwent a kidney transplant due to CKDu, can
Okay.
this condition recur in the transplanted kidney as well?
Yeah. So once patient get transplant as a new life, so again the patient's exposure to the environmental toxins can occur, or the patient's CKDu might be due to familial tendency. It can occur.
Right. Okay, sir. There's one more question in the chat box, sir. Can't we diagnose CKDu in people less than 17 years of age?
So usually that our guidelines and other research findings are more than 70-year-old patients are exclusion criteria, but in clinical setup, the background history of endemic area and their agriculture, and these are the entry criteria of CKD, fulfilling of CKDu. So we can take it as CKDu, but yeah, that's depend on that. The EGFR 70 is not exclusion, but usually we are excluding, but it can occur. So maybe asymptomatic, so until the end of the age, so suddenly patient will develop medical or any other fever or something, we can encounter the creatinine high. So maybe due to CKDu. So that is very difficult to say that.
Okay, sir. There's one last question from Piumi to everyone. That is place of renal transplant in CKDu.
So what's place mean? They're asking is patient need a transplant or so whatever CKDu, whatever etiology end stage is, until patient develop CKD stage 5 or CKD end stage, that is CKD. So whatever cause. So any patients, whatever etiology, we are recommend for the transplant. The only thing is recurrence, but CKDu I don't think it's maybe because of this environmental risk factors are limited, or preventive method we can no chance of recurrence.
Right. Okay. That's those are the questions we have, sir. So I would like to thank.
Snake bite and envenom linked to the CKDu. I'm not sure. Usually the leptospira and Handa, they are culprit for CKDu, but snake bite and envenom, I couldn't find. I'm not sure about that, but probably it's not.
Okay, sir. Right. So that wraps up the today's session. I would like to thank Dr. Sasikanth, acting consultant nephrologist, District General Hospital Vavuniya, for his valuable time and for joining it in with us today on a Sunday morning to share his knowledge about CKDU. And I would like to thank all of you for joining in with us today. And I'd like to invite all of you to join in with us in the next week as well for our weekly Sunday webinar series. So we'll find the link for the e-certificate in the chat box. Please follow it and get your CPD certificate. Again, I would like to thank Dr. Sasikanth for his valuable time. Thank you, sir. And I would like to wish you all a good day. Happy Sunday. Thank you very much.